Hi guys! This video is about gluteal tendinopathy, which gives you pain over the outside of your hip. Now, what we're going to cover is we're going to look at what gluteal tendinopathy is, what it feels like, so how can you know that you've got it, how it's diagnosed. Then we're going to look at who gets it and what the risk factors are. Why do you get it? And lastly, we're going to look at all the treatments, and I'm going to discuss how you choose the exercises depending on the stage of the tendinopathy as well, and how you can progress that, and also what to do if exercise doesn't seem to be working. My name is Maryke. I'm the physiotherapist from sportsinjuryphysio.com, where you can get online physiotherapy assessment as well as treatment for your injuries. So check out my link to my website in the description of this video if you want to know more. Good, so let's start at the start. What is a gluteal tendinopathy? Now, your gluteal complex muscles, or actually your bum, has loads of muscles in there. So you've got your glute max is the big one over the top, and then you've got your glute med and glute min that kind of lies over each other on the side of your hip. And when they look on MRI scan, gluteal tendinopathies happens in the tendons of the glute med and glute min muscles most of the time. It causes... Basically what a tendinopathy is if you overstrain the tendon. Now, in two ways, it can be forces that goes through the tendon that's too high, or it can be compression forces where the tendon's compressed a lot that brings it about. And when you look at a tendon that's got a tendinopathy in it under a microscope, you'll see that the collagen fibers, which is normally aligned parallel with each other, which makes the tendon really strong, are now moving slightly away from each other. The cells are different sizes, so usually larger cells in there, and essentially the tendon becomes softer than what it should be, and it loses its capacity to cope with force. The pain that you feel from a tendinopathy or a gluteal tendinopathy is very much over the side of the hip, over your greater trochanter, which is that bony bit. I wonder if I can show it if I'm on my side. There we go. Yes. So if you feel your bony bit here on the side of the hip, it's in this area and kind of around this area that you get the pain from a gluteal tendinopathy. It can refer down the side of the thigh as well, and a little bit into the back, into your buttock. But most of the time, that's where the main pain is. It's really painful to sleep on that side. Sometimes it can even hurt if you're lying on the opposite side and that leg is on top, because they don't like to be stretched. Any activity that takes your weight on one leg, so we're talking running, walking, jumping, anything like that can aggravate it. It's different for different people because tendinopathies come in different stages. So some people may only have pain with running or after they've run. Others may have a lot of pain just walking or trying to do the stairs. So that is different for different people as well. Sometimes sitting in deep chairs and then trying to get up out of it can be quite painful, but the pain is always over that side of the hip or a little bit towards the back of it. There are other things that can feel very similar to gluteal tendinopathies. So lower back pain can refer into your buttock, but if you have lower back pain that's causing your pain, you'll often have a stiff back as well, or some discomfort in there. Piriformis syndrome, loads of other conditions that affects the glutes can cause pain in that area as well. What the research is showing is that if you have pain over that area where if you press over that bony bit around the area of the greater trochanter and you don't have any pain there, it's likely not gluteal tendinopathy. If you do have pain there, it may very well be. Another test that usually gives you a positive if it is a gluteal tendinopathy is if you balance on one leg for 30 seconds. That usually starts to hurt in that area as well. But it's not for everybody. MRI scans are the best at diagnosing this condition because also they can quite often accompany bursitis. So you may have gone to your GP and they've pressed on there and they've said, oh, I know what you've got a bursitis, greater trochanter bursitis, they may even call it, or a hip bursitis. But what we know now is that yes, you often get a gluteal tendinopathy with a bursitis, but you don't often get a bursitis on its own. So bursitis per se is not enough of a diagnosis. It often accompanies other conditions in that area. You'll often also hear that people talk about trochanteric syndrome these days. And it's because they now realize that when you have pain in that area, often it's not just one structure causing it. It's a combination of things, like you'll have a tendinopathy plus a bursitis. So there can be more than one thing that can cause it. But MRI scan is the best way to diagnose it. But you can be pretty accurate from just listening to how the pain has developed. It's usually a gradual onset with it. And also where people feel their pain, and then do those 2 clinical tests that I've just talked about. There are loads of other tests as well where you can put the muscle into stretch positions. If you try to stretch your glutes out and it hurts like mad afterwards, also a sign that it can maybe be that, because a tendon that's got a tendinopathy in it often doesn't do well with stretching, and gluteal tendons definitely doesn't like that in the early stages. And I'll talk about that a little bit more during the treatment phase of this. Right, let me just make sure that I'm not leaving anything out. Oh yes, of course. Osteoarthritis in the hip can also cause similar symptoms, but an interesting difference between the two is that when you've got osteoarthritis in your hip joint also becomes really stiff. So people who has that often struggle to reach their feet and put their shoes and socks on because it's very difficult to bend down. Whereas if you've got a gluteal tendinopathy, it may be painful, but your range of motion is not restricted. So you can actually reach your toes and you can put your socks and your shoes on. And that's actually been shown through the research, which is quite an interesting thing, because when I read that, I went, yes, of course. Because one of the biggest complaints when people come with osteoarthritis in their hips to me is that they can't put their shoes and their socks on. What else have I left out there? No, that's everything under diagnosis. Now, who gets it? So interestingly enough, like with most tendinopathies, people who are sedentary, who doesn't do any exercise, gets this. And then people who does exercise, especially things like running, also gets it. And it's definitely more prevalent in females over the age of 40. Now, that may be linked with the menopause, but I haven't found research that's linked that definitively, the two things. But we know that with the menopause or perimenopause, as females' estrogen level starts to drop, it affects your collagen turnover. And tendons are mainly made of collagen. So it's much more easy to injure a tendon then. So that may be why it's more prevalent in women over the age of 40. But that said, men also gets this condition. It's just more prevalent in females. Maybe if I explain to you how the glutes function, you'll understand why you get it. And then I'll talk about the other risk factors a little bit more, because then it'll make more sense. So let me shift this back a bit. You can see me a bit better. Can you see my hips there? Yes, that's perfect. So standing on 2 feet, you can see that my pelvis is nice and level, although it doesn't look level, but I think my camera is a little bit askew. But they're both taking equal weight. Now, if I shift my weight over onto one side, I'm now having to use my muscles on this side to keep my pelvis level. So my glute med and my glute min are working really hard to contract to keep all of this level. Now, should I drop this hip, can you see that those muscles are now lengthening over there, and they are now going to compress against this bony bit there. So especially in people who walk or run with hips that does that when you're walking or running, will put more strain on that tendon and more compression forces. And they think that that's one of the reasons why people get that. Also, if people are in a habit of standing like this, can you see that I've got to compress that tendon again over that area, and that may cause injury to it. So risk factors for this is if you run or walk and your leg turns in dramatically or a lot, that can cause compression and extra strain on that tendon. Also, if your pelvis drops, so weak core muscles and weak hip stabilizers can predispose you to this. Then a rapid increase in your training load. So for instance, say for instance you've had a long break from running and you suddenly start back running and you do loads of hill running, especially downhill where you're pounding it and your muscles aren't strong enough, that can cause a gluteal tendinopathy. Or you've just had a baby and you're coming back to running after several months of not doing anything and being really deconditioned. That again is a perfect scenario for those muscles to take too much strain in the tendons and to get a gluteal tendinopathy. So yes, the main theory behind why it happens is it's to do with the tendon's proximity to your greater trochanter and the bone there, and also the IT band coming across that can compress onto the tendons. What am I leaving out here? Oh yes, of course. If we think of running a gait again, yes, fine, dropping the pelvis too much or the leg turning in, but also if you've got a narrow gait where instead of your feet following a nice parallel gait, you kind of cross over as you place your feet. So there's a big angle in where the leg goes relative to the pelvis. That can cause more compression there. My head's just gone. Yeah, that's basically all of them. So now remember that when we get to the treatment bit, because we're going to apply these principles when we want to offload the tendon to get the pain to go away. One of the other things that is a risk factor for people to develop this condition is if you're quite overweight, and that comes down to the loads that goes through the tendons with each step you give. Good. So I think I actually had a picture of that as well, but I have kind of demonstrated it. So you can see on that picture, again, because my pelvis drops in that picture and my leg turns in, you can see that angle that it forms at the hip, and where that muscle crosses over that side of the hip, it's going to pull it tight and put a lot of force through that tendon. Okay, so come on, where's my... Oh, there we go. Actually, I think I've skipped one. So, treatments. The first bit of treatment is, and the bit that gives people the best pain relief at the beginning, I find is just advice, to be honest, because you'll be surprised how many daily activities people are in the habit of doing that actually compresses that tendon or strains it. So remember, it doesn't like legs crossing over. So when you're sitting, are you in a habit of crossing your legs? Then definitely get out of it and don't cross your legs when you sit. Avoid chairs that's really deep, because when you're in that deep flex position with your hips, that can strain part of the gluteal tendons, and that can cause pain. If you're standing, are you doing that thing of hanging off your hip waiting for somebody? Because if you are, you've got to get out of that habit and start standing on 2 feet, because otherwise you're just straining that tendon. If you're sleeping, you may find that, yes, sleeping on that side really hurts, but even sleeping on the other side and with that injured leg on top can hurt after a while. And it's because when you're sleeping, that leg is just slightly in a stretched position, and over time that can irritate the tendon. Often my patients even find that one pillow between the legs is not enough, that they need 2 cushions between their legs if they want to sleep on their sides. But if you're not into building towers while you're sleeping, you can always sleep on your back as well, because that won't strain the tendon either. So definitely look at the things you're doing in the day. Are there periods in the day where you're stretching the tendon that's causing the pain to continuously flare up that you don't have to be doing? You've got to adjust those things. Then, second and very, very important is relative rest. So relative rest means you don't have to stop all activity, but you definitely need to stop the activity that aggravates it. Now, with all tendinopathies, you may not feel the pain while you're doing the activity. So you've got to measure it or monitor it for 24 hours. So if you're doing a run at the moment, it feels absolutely fine, but then 3 hours later, you're really achy, and especially the next morning, you're really stiff and sore. That means that run isn't right for you at the moment, and you're continuously straining the tendon. So it may be time to actually rather go swimming or go cycling. Do something that offloads the tendon, that allows it a period where you can strengthen it back up so that it can cope with running again. And it's quite useful to work with somebody who can help advise you and help pick that apart, because sometimes you can't see the obvious things because you're inside that moment too much. Then, from a hands-on point of view, I found my patients responded really well to dry needling of those muscles because they often have trigger points that's really painful. You have to understand that dry needling and massage, those two things won't make it heal any faster because the tendon needs basically to be offloaded, relative rest, and then have a strength training program. But dry needling and massage can help with pain. That said, if you're going to go do massage and really dig in with your elbow, that poor patient is going to be in agony later that day and even for a few days after that. So you've got to be very gentle with it, but firm. So if you're worried about, are you pressing too hard when you massage or you're not pressing hard enough? A good guide is it's got to be comfortably uncomfortable. If the patient feels that it's painful and really uncomfortable, it's too much. They've got to be able to tolerate it, otherwise it's too much. And even if you do it at that level, they may still come back and say, oh, I had pain for 2 days. That is not okay. It's okay if it feels a little bit bruised the next day, but it shouldn't be agony and it shouldn't be really painful. You can also do massage for yourself. So you can use a tennis ball or something and just be side on, sit onto it. Or I find it more useful to do it against a wall, that you literally just put the tennis ball between yourself and the wall and do it that way, because then you can monitor how much pressure you put through it a little bit better. I don't have my tennis ball with me at the moment, but let me just demonstrate it. So pretend what I would do is I would place the tennis ball between myself and the wall, so kind of in this area where the muscles run, and then this leg that's against the wall, totally relax it, push with the other leg into it, and then you can angle yourself at different angles to get different parts of it. And you can either just hold the pressure on that painful spot or tender spot for about 30 to 40 seconds and then move on to the next one, or you can roll it around. It's up to you, but I find it quite effective if you hold the pressure for a long period of time on one point before you move on to the next point. Then we get to exercise, which is the bit I actually wanted to get to. So whenever you've got a tendinopathy, the tendon loses its capacity to cope with the forces of your daily activity. And what that means is essentially it becomes weaker. And the longer you've got the pain, the more the muscles also become weaker. So you've got to strengthen all of that back up so that it can cope with the things you want to do. But if you jump into strength training too quickly and too severely, you may make your pain worse. So here's what you've got to think about. When we think of exercise training for this condition, there are 3 things you want to look at. You want to look at your glute med and min specifically, so strengthening the muscles that's involved, the tendons involved. But you also want to strengthen the muscles that support them. So if we think of the muscles that supports your pelvis and everything in that position when you're running or when you're on one leg, just walking or stairs, depending on what you do, the glute max actually plays a massive role there as well. And your core muscles to control your pelvic stability there. Then movement patterns. So remember, I demonstrated that if you allow your pelvis to drop or your knee moves in too much, that can cause more strain on the tendon. Now, what the research is showing is often when we strengthen these muscles that need to control that, if we don't go and teach the people the movement pattern, how we want them to move as well, it doesn't translate. So we've got to do exercises that teaches them that movement pattern, how they should be moving. And it's not rocket science, it's really easy. I'll talk you through it in a minute. Okay, so moving on. If we move on to, first of all, your glute med and glute min specific exercises. Now, remember, especially in the early stages, it's a compression type injury this. So if you're going to allow that tendon to go into stretch position or positions where it's compressed, it's not going to love you, it's actually going to hurt. So you've got to work, we start with isometric contractions, which means you're just holding the leg in that position against resistance, but it's not actually moving. So to give you a good example of that, actually let me demonstrate it. It's going to be easier. Get this thing out of the way. But I need some cushions for this. It's quite handy to do this in your bedroom because then you've got loads of cushions. Okay, so one of the simplest exercises to do is probably let me just see what I'm doing. Side leg lift. But now, can you see, I'm going to take this away for a moment, just so that you can see me fully. There we go. So can you see, as I'm lying here, because of the size of my pelvis, my leg drops down. So this tendon is already stretching there. So if I had to sleep like this, and this is an injured tendon, it will hurt after a while. Now, if I do my exercises and I do side leg lifts like this, because it's going into a slightly stretched position, that may hurt as well. So what I find for my patients is if I can prop their legs up at the beginning, that actually, can you see, we're not working in a compressed position or a stretched position at all. We're keeping that well away from there. So what I would do is get them to hold that and work from there. And we're just doing isometrics. So in this position, they're actually just holding it. It looks as if I'm resting it there, but I'm holding it there. And I'm not moving up or down. I'm literally just holding it and engaging my side there. Of course, it depends on the person. Some people may be able to go past this immediately, but this is a good place to start with isometrics for it. You can also do it with people lying on their backs and just putting a band around their legs and then pulling it in this position out and just holding that position against the band. Okay. But now remember, there are other movements that also causes tension in the glute med and glute min where they work, but they don't work maximally. So one good example is just a glute bridge. So it's not massively active in that position, but it's enough to get it going. And you're also strengthening the muscles that actually supports or has to help support them. So we're getting the glutes working. And you may even be able to progress it later on to single leg ones, where at that point, the glute med is starting to work a bit more. Another example are double leg squats. So if we think of the movement pattern that you use for running and stuff, a double leg squat is a great movement to start teaching people where they need to be trying to control their legs when they're running. So let me show you what I mean with that. If you do a squat, but I think you need to see a bit more of me. Let's see how that is. That looks better. So if you do a squat, if you think of the position that would hurt when you run is when your legs turn in and it goes like that. So using a normal squat, teaching people to keep their knees in line with the middle of their foot and in good alignment is a good way to start getting some strength through the quads, getting some strength through the glutes, but not actually straining the glute med or min. And if you want to work them isometrically, you can even put a band around here so that they've got to pull out while they do that. But word of warning, with this condition, I would be more conservative first. Often people when they come in are in so much pain that if you do those active movements with them, they don't cope well with them. So start with isometrics in side lying or something, but go according to what your patient can do. So definitely, I hope you understand the concept of don't take the muscle into those stretch positions at the beginning. So that would be for isometrics. Let me just see, where's that slide now? Okay, then we move on to isotonics without compression. What does that mean? So our isotonic movement is where you do both the concentric and eccentric phase. If I can use my side leg lift as an example again. So if we think of isometric was you were just holding it in that position where there's no compression, just holding it for 10, 20 seconds, depending on what the patient can do. Now, isotonics is we're going to lift it up and just move in this position, but not into compression yet. So we're doing our side leg lifts in this position and the cushion is stopping me from going all the way into a compressed position. Again, you may need 2 cushions between there depending on the patient. Then, as they get better and the tendon calms down, you can start taking the cushion out, and now we're moving into a position where the tendon's slightly more stretched, but because it's calmed down and you've worked towards this point, it can handle that. And also, usually when it starts coping with going into this position, slightly compressed position, it can cope better with your standing exercises or more loaded exercises. You have to eventually take it into low load positions where people are in single leg standing and stuff like that. So how I would progress things with regards to squats to single leg squats, I normally get them doing a normal double leg squat, preferably with a band around the knees, have to pull it out, work on that control, then get them maybe into a Bulgarian split squat where one leg is supported on a bench, other one at the front, so they're doing a single leg squat, but it's still controlled because one leg is helping to stabilize, before I then get them onto some form of a single leg squat to control. But again, this is dependent on the patient. If I've got a sedentary patient who never runs, who only walks to places and just wants to get around the house pain-free, I'm not going to bother with single leg squats because it's more load than what she really needs. But for runners, definitely go through that, and they've got to do plyometrics and things as well. And when they go back to running, I give them cues to think about, like for instance, when you run, make sure your knees are pointing forwards, because that immediately is a cue for thinking about, do I feel my leg turning in? If I do, no, keep the knees pointing forwards so there's not that much strain then on the hips. Good, so let me know if that doesn't make sense. I'm happy to answer any questions. Now, if exercise doesn't work, then there are other treatments that can be useful. Shockwave is one. But shockwave is a little bit of a problem if you've got a patient who's on the bigger side, because if there's a lot of fat between, let's face it, as females we often get big bottoms, that's where our fat goes. So shockwave only really works if the shocks can get to the tendon involved, and your glute min and glute med tendons are already really part of the deep layers. So if you've got a big layer of fat over that, shockwave may not be that effective. Corticosteroid injections, yes, especially in the short term, they provide really good pain relief, but there is quite a high recurrence rate with them. But it may be down to lack of proper rehab afterwards, because the people feel fine, they don't do the exercises necessarily. So if you've got somebody who's got a really painful tendon and you just can't get anywhere with the exercises, a steroid injection can make a difference, but it has to be followed up with a proper strength training program afterwards. The research on PRP is actually starting to look pretty good for this condition. So what it's showing is that it's got similar effects than corticosteroids, not as good in the first few weeks, but if we're looking long term, it's got much better outcome, and people do much better if we look at 2-year follow-ups when they have PRP injections versus corticosteroid injections. Excellent. Let me know if you've got any questions, and if you need more help with the injury, you're welcome to consult me via video call. Link of my website is in the description of this video. Take care.